Well, I think we'll begin the webinar. Thank you all for joining us today. We have several presenters as we go through, and we'll introduce them in just a moment. Today's webinar is focused on the topic of when claims data aren't enough, how employers measure, benchmark, and use productivity outcomes. So let me talk a bit about the new employer realities that we're seeing in the marketplace today. First, and I think perhaps not insignificantly, more and more employers at the HR, benefits, and risk management level need to show to their C-suite the value of improved workforce health. It's no longer about benefit costs alone. It's also about the value of the investment the employer is making in health and related programs. Secondly, and I think closely related, is healthcare reform. Question is, do we stay in healthcare? Do we get out of healthcare, send our employees to the exchanges and get their medical care there? Or do we really focus on the health of the workforce as part of our economic productive engine and really maximize our health programs to drive business value and business outcomes? And I think that conversation over the next 2 years will be critical for employers. As a result, employers, I think, have realized that attempting to control claims costs in separate benefit program silos is a dead end. You can't manage costs by managing claims. You can only manage costs and only manage productivity outcomes by focusing on the health of the population. And I think one of those key things for employers, and a lot of the time employers miss this, they think if they shift the cost and risk for health insurance and the like, they've shifted the cost and risk for health. And in fact, productivity outcomes, absence, disability, and performance always stays with the employer as a cost issue. So employers are looking for new strategies and better strategies to go beyond their traditional focus on claims costs, particularly in the group health program. Now, one of the models we built here at IBI, we call it the full cost estimator. And we run this model in a number of industries. This shows the results for the auto industry. And actually includes medical care both for employees and spouses. And we show here what we call the full cost of health for this industry, about 170,000 employees. A little less than half those costs are medical care and pharmacy benefits. About 24%, 16%, and 8% are focused on absence and disability, the wage replacements, as well as the productivity loss when employees do not come to work. And 28% is the cost of performance, what's been called presenteeism in the research literature. That is, people coming to work with chronic health conditions and not performing to their full capacity. And this is the very reason that employers are starting to look beyond claims as a way to think about health. The issue of productivity is absolutely fundamental to employers if they're really going to maximize the value of health investments. Now, let me just spend a minute talking about productivity, because one of the reasons that employers undertake self-reports is to get a better sense of the productivity loss associated with lost work time, both absence and performance. When we talk about lost productivity here at IBI, we focus on the financial impact on a company when employees are not at work and fully functioning. The two pieces to that are absence. Someone doesn't show up for work that day, their wage replacement payments, and in fact, the employer responds to absent employees through a variety of different mechanisms. Sometimes employers have a bigger staff. Sometimes they use overtime. Sometimes they have temporary help. Sometimes they lose revenue because key people aren't at work delivering the products and services that are key to the employer. The other side of this, the presenteeism side, when someone's coming to work and not working a full day because of the impact of their chronic health, and I think depression perhaps is one of the really good examples of that. The two pieces, on the one hand, the employer is paying that person for a full day, yet in a sense they're not getting a full day of work from that person because of the impact of chronic health. So there's a wage and benefit overpayment because of the impact of decrements in performance. And at the same time, the employer has to respond to the fact that the employees are not working that full day. And it's the same issue, the opportunity cost of how the employer responds to that issue of underperformance based on employees with chronic health conditions being at work but not performing. This productivity analysis, this productivity model was published in Health Economics in 2006 based on research by Sean Nicholson and Mark Pauly with 800 employers on the true cost of lost work time in their businesses. So with that as background, let me talk about the study that we'll go through with you today. A little background and design of the study. As I said, we're moving from a period of managing costs to managing population health, which is the way to really control and maximize the value of health in the workforce. As part and parcel to that, employers are having to take steps to quantify the productivity consequences of workforce health. That is part and parcel to this discussion. That is certainly part of the equation in understanding the value of health improvement and health investment. And I think the other thing that employers are doing right now is they're recognizing that by only looking at medical and pharmacy claims data, they're getting a very good window into the chronic health conditions that are being treated. But I think most employers realize that when their employees have chronic health conditions that are not being treated, there is an issue around productivity even when there's not an impact on medical and pharmacy claims spend. And I think this is another reason that employers are turning to self-reported information to try to get a better sense of the chronic health conditions that might exist in their workforce, which are affecting absence and productivity, but may not be treated in the medical care system. So we really felt, John Riedel, who's one of the presenters today, and I felt that it was really time to start to dig into this with a series of case studies with employers that really are on the leading edge of looking at self-reported information as part and parcel to their medical care and their health care strategy. So we wanted to use this research as a way to raise the awareness of the current use and applications of a variety of measurement tools. And there are a variety out there. We'll talk about those in a minute. But we wanted to make sure we could translate those measurement tools, which by and large have been developed in the academic space, into the space for employers. So they have to be applications that employers can use in an efficient and effective manner. And I think the other thing, we wanted to really start to get at the issue of the skepticism around self-reported measurements. Now, I think this is rather curious because employers have used essentially employee self-reported information for a wide variety of issues over a long time. Many employers do surveys of employee satisfaction in their organizations. So self-reporting is not new for employers, but tying it to health, I think, is somewhat new, and there has been some skepticism about that. Now, let me turn the presentation over to John Riedel. John, I'm sure many of you know, John has been a research partner of IBI for a number of years. John is really the driving force behind the case studies, and John will take us through the rest of this part of our presentation, and then we'll hear from two employers who I'll introduce when we get there. So, John, take it away.
Thank you, Tom. Thanks, everybody, for joining us. As Tom mentioned, we decided on a case study approach and wanted to get a group of employers who represent a wide range of industries, sizes, and geography. We also wanted employers who used a variety of measurement tools and use them for different purposes to kind of cover the waterfront as much as we could. We also wanted employers who'd been doing measurement for several years and those who were just getting started. So you can see the 9 case studies, the 9 employers that we included here, and we're pleased to have HC21 and Pinnacol Assurance on this webinar, and they're going to talk about what they did and how they've used their findings. We wanted to learn from employers who were also struggling. We weren't just looking for success, and yet most of the employers here were pretty successful, and we'll talk about how so. I do want to mention that the resource that we're talking about, the case study resource, is called Workforce Health and Productivity, How Employers Measure, Benchmark, and Use Productivity Outcomes. And you can get a copy of this, and I think we have a slide that will show you how to get your hands on one. And all the stuff that we're going through here is incorporated there to one extent or another. Just mention, too, that The information that we generated came from primarily two sources. We did do an internet-based survey with all the case studies, and then followed up with pretty extensive personal interviews, and oftentimes there were several interviews over time. Okay, the next slide talks about the measurement tools that we used. We were able to get a pretty good match of case studies with some of the more popular instruments. You can see here that the four that are used are the Health and Work Performance Questionnaire, the Wellbeing Assessment, which is a fairly new entry to the marketplace by Healthways, the Work Limitations Questionnaire, and the Work Productivity and Activity Impairment Questionnaire. There are probably 17 or 18 tools in the marketplace. These tend to be the ones, or four anyway, that are pretty widely used. Okay. Oh, I should mention too that in the resource we've provided a pretty detailed description of each tool. So what did we look at? Here's an overview of the factors that we explored, and I'm going to do kind of a quick and high-level summary of these factors. We organized them in the resource in a way that you could easily get to the specific case studies that might be of greatest interest to you in terms of what you're trying to accomplish. And so organizational dynamics includes issues like senior management buy-in and corporate culture. Why did these case studies opt to do self-reported measurement, how they selected their tools, how they went about implementing, how they used the findings. We thought it was really important to have a focus on how do you make health and productivity measurement and management stick? What are some of the things you can do to really build it into the fabric of the organization, and what are some of the key lessons learned? Okay, so just a quick backdrop on the time frames. You can see that Aetna is the old-timer. They've been at this for 8 years, almost 9 now. Eastman Chemical and Dow Chemical started in 2005. In 2010, the newer entrants, American Express, Caterpillar, and Lincoln Industries, began engaging in this. And all of these companies are conducting either annual or semi-annual measurement on an ongoing basis. Okay, so kind of a really high-level summary of key findings, and I'm going to get into this in a little bit more detail and to some extent set the stage for Gaye and Vanessa. 4 organizational factors are really important in deciding to do measurement and really using the findings, and I'm going to go over those in just a minute. Clearly, self-reported data is considered the gold standard. All of the case studies really believe this. The only way to really get at this sort of information is to do self-reported measurement. Tool selection validation is really the top issue, and I think that goes back to Tom's concern about the skepticism of self-report and his comments on that, which we were trying to have some impact on with this resource. High participation, of course, with regard to implementation is a key. And I think the overriding sentiment here, what I heard from these 9 case studies, the single strongest piece of advice, I'd say the key learning is just get started. You really don't know what you don't know until you do measurement, and I think you'll hear that from Gaye and Vanessa to a great extent as well. Okay. So some of the findings, and I won't spend a whole lot of time on these, but senior management buy-in is one of those key issues. You can see here of the 9 case studies, one of them indicated they had relatively low buy-in by senior management. And what's interesting is that one case study was more on the line of an organization that kind of struggled with this, and so this is that organization. Key to have senior management buy-in. I think we all know the importance of that. What we asked about strong buy-in, meaning that you have leaders as champions, and we found that kind of buy-in really results almost universally in access to a wider range of corporate assets. The one organization that had low buy-in really struggled in terms of getting the assets they needed in kind of in all phases. Okay, the next one is culture of health, and I think pretty closely ties to senior management buy-in. It's hard to create a corporate culture of health if you don't have senior management buy-in. And again, 8 of them felt that they had created a moderate to strong culture of health. And the question we asked is, do you focus on employee health asset management as a key to success, as a key to corporate success? And so clearly important factor. The next one is the level of benefits integration. No one's doing health and productivity self-reporting without considerable leadership from other business units. And they include corporate medical benefits, occupational health and safety, marketing, communications, finance, and human resources are some of the key ones. But everyone here is either doing kind of cross-functional or coordinated benefits integration. And it's interesting, 5 really indicate that they have fully integrated in that regard. And then the last one is health metrics integration. And we asked the question, how well integrated are your health metrics with other health measures like employee assistance programs, workers' comp, disability, FMLA, group health, and that sort of thing? And we see that 8 of them say they're moderately integrated. Only 1 was fully integrated. I think most of these employers are really moving in that direction, but I think the point here is that the ones who have been successful here have really done a reasonably good job of starting to integrate their overall health metrics. Okay. What did the case studies talk about in terms of the rationale for doing self-reporting? Really, as Tom was saying, employers have been doing self-report for a long time, but it seems there's skepticism around the issue of health and productivity. So how do you sell or tell your CFO or your CEO that you're going to ask employees to rate their own productivity, and then you're going to use the data to allocate health resources? For some, that's a tough sell. But here's what we heard, that these companies have relied on self-reported measures for years, as Tom said, employee satisfaction surveys and HRA. The science behind self-reported measurement is really well grounded and is being developed by groups like Harvard Medical School, Tufts Medical Center, and Gallup, just to name a few. So the sense from these case studies was, it's for us, it's not a terribly hard sell with our management. Okay, but with regard to tool selection, this is what we heard. There were kind of 5 factors in terms of which tools were selected for use. Every case study did a pretty extensive due diligence process, and one of them used a Six Sigma process. But these are the mentioned. The strong validation, number 1, it's got to be believable. And the measures and the tool has to be consistent with the kind of initiatives that are being developed. So it's important to have some clarity around what you're trying to accomplish. What is your plan with regard to doing measurements, so you can assure yourself that you're going to get the right tool. Ease of administration, and that's, I think, increasingly being assured by tying to an existing HRA. I would suggest, I don't know if this is the case, but that there are probably few HRA vendors out there who aren't incorporating some productivity questions and measures in their tools. Low response burden is really important, and that ties to the issue of engagement, making sure participation is as high as possible. And then clearly the capability to integrate with other health data. And it goes back to Tom's focus on understanding the full cost of employee health. So that's a pretty critical piece. Okay. Lessons in measurement. Here are 4 things that we heard. High participation, obviously, is the primary objective, and so how do they get there? Well, tie it to an existing HRA pretty much across the board. Few are doing separate productivity measurement initiatives. Guaranteeing confidentiality is key for high levels of engagement, but also to make sure that you don't get a high percent of socially kind of desirable responses from people. You want them to feel very comfortable that they can be honest. Providing incentives is being done by almost all of the case studies, and I think this makes some sense. These are extrinsic rewards, primarily, giving people gifts, giving them a lower deductible, tying it to, say, their premium amount and that sort of thing. And I think that works with something like a productivity measurement tool, something very simple and easy to accomplish. We can go into that. I've been doing a lot of work on extrinsic versus intrinsic incentives lately, and so I think we have to be very careful about not providing or not focusing just on extrinsic, and make sure that you communicate. I mean, this is often a tag-along kind of an issue, but these case studies really focus on getting the message out to their people. Okay. Using the findings, what I'll point out here, and I'm not going to get into this in any detail, but the way that we created the resource that's available to you, if you choose, is we kind of looked at three different ways of applications, from simply understanding the magnitude of productivity loss, that would be a descriptive approach, to a comparative approach where you start to look at in more detail what kind of factors are driving reduced productivity. Obviously, health risks and chronic conditions are two key ones, but engagement, well-being, corporate culture are really starting to gain traction in this area. We're seeing more and more of the tools starting to measure those kind of issues. And then evaluative, which is I'd say at this point in time is still our weaker link. How do improvements in health status correlate to productivity gains? It's important. Most of the case studies were doing that, but I think that's still in our field probably right now one of our weaker links. Okay, getting to making HPM stick. I did want to mention a few ideas along the lines here, and maybe some of you are struggling with how do we go about taking a new and promising idea and not only generating interest, which oftentimes we can do early on, but either maybe it wasn't effective or maybe it was effective but didn't have staying power. So we've all gone through these kind of boom and bust cycles. So what are some of the ways that we really, over time, get these kinds of initiatives built in? And just some examples here. Eastman Chemical, one of the case studies, brought all their expenditures and decision-making around HPM right to the corporate level. So all funds that are spent here are budgeted along with group health, disability, vacation, and so on. And changes are made on a corporate-wide basis. Aetna indicated that you got to first build it into the corporate strategy, make sure senior management supports it, and I think the key here is don't assume senior management buy-in lasts forever. You've got to really keep them engaged. And in my favorite, and I think we all probably know Lincoln Industries, they have really created a culture of health. This is so key to them. They say really the best way to make an initiative stick is to begin thinking that way. So it's one thing to have this documented in business plans and all. It's really a whole nother level to make sure that everybody who's working there, from the top person down to the person who cleans up on the weekends, everyone really needs to be thinking in terms of health and how it affects productivity. And then finally, for my portion, just kind of mention the lessons learned, and I pulled these out from the case studies. I don't think there's anything really new, astounding, sexy here, but all the things that we probably are all aware that we need to do. You just got to get started. That again is, I think, the top most important issue. You need to create a plan. You have to have clarity about what you're trying to accomplish. The data are critical. They're critical to the CFO for sure, and I know IBI has done a lot of work in that area. But also the data is really critical, and all of these case studies use the data that they generated to develop programs, to modify programs, to generate different kinds of communications approaches and that sort of thing. Got to engage leadership. Develop support system is really key, and I was interested when I saw all the range of support systems that the case studies had. That goes from kind of cross-function councils where you've got all of these different groups within the organization meeting on a regular basis, providing input to employee advisory. So you've got the person who you're trying to contact really engaged in some of the decision-making too. Communicate to the front lines and engage. So that's a kind of a high-level, very brief summary. As I mentioned, we're happy to share with you the resource if you want to get into this in any more detail. And here's how you can get a copy of the study. Either contact Tom or myself at these email addresses, and we'll get you a copy right away. And I'm going to turn it over now, or back to Tom, who's going to, I think, turn it over to Gaye.
Good. Well, thank you, John, very much. It's a high-level overview, but we really want to make sure we have time for our two employers presenting today. And I have information on the two employers. Gaye Fortner at Healthcare 21. There's Gaye's email address. Healthcare 21 is one of our great employer coalition partners here at IBI. Following Gaye will be Vanessa Newport, HR manager at Pinnacol Assurance. And with Gaye this morning will be, with Vanessa this morning will be Claire Brockbank of Segue Consulting, which is a key partner of Pinnacol Assurance. So let me just take a minute and bring up. Okay, Gaye, take it away.
Thanks, Tom. I appreciate the opportunity this afternoon to talk with everyone and tell you how our coalition has supported and led our members to look more specifically at health and productivity and tie that to their health risk management programs. We are a nonprofit business coalition located in Tennessee. We cover the east and middle part of Tennessee with our membership. We have about 90 corporate members with about 500,000 lives under our coalition umbrella. The majority of our employers are mid-size employers in the 2,000 to 3,000 range. And I wanted to make that point because I think it's important for those of you who aren't jumbo companies with lots of resources to know that there is really meaningful good work that you can become acquainted with and start doing to get started. We also have a number of smaller 400 or 500 member employers as well as several jumbos. Healthcare 21 has a sister company called Healthcare 21 Solutions that we actually have expanded some of our products outside of the state of Tennessee. So looking at the next slide, there are two key components to our initiative. We've really been working away at addressing health risk for about 7 years. We started with the low-hanging fruit of chronic care, and through our work with a data cooperative, we actually can house our members' claims and RX data. So we bring their data in-house to our data integration system and do analysis work for them. In our claims database, we have, as I mentioned, the medical claims and RX. We can put in biometrics, lab values, health risk assessment, attendance data, short-term disability information, vendor reports, program measurement. We really have a robust system. And what we have done is integrate all of these feeds where we can take an employer and look at a program down to the individual participant level and do some very intense analysis. Our data integrator probably has about 60, 65 feeds coming into it now from various plans with near 175,000 lives in it. The other part of our work has been around developing a health risk management model. And I know this is a busy slide, but if you will think about how we work with total population management, looking at not only employees but also spouses and dependents, we need to identify who is in the pool of people that we're responsible for in the management. And so you can see in this data management bar going across the different ways that we might mine and find who is in our data pool. Participation is a key component of the risk management model. And this is where we're looking at the things that impact consumer engagement. What is the culture of the company? How are incentives structured? What's the communication plan over the course of a program that they're putting into place? And how does the work environment affect the engagement? All of those factors have equal importance when you start putting a successful program together. And then in our intervention work, of course, you're looking at the various types of things on a continuum that help with the management of the health risk, from prevention all the way down to the more serious case management, and the things amongst specialty services that might impact that. You can see off to the far right-hand side the return on investment measures that we're looking at for our programs. And I think it is important that your programs include not only what the claim impact is, but what the clinical outcomes are. How are those lab values changing? How are the work and productivity skills improving? These are very meaningful measures that the employers like to look at. So from our work on the risk management model, we developed something called the Chronic Care Network. This is about 3 to 4 years old now. It was an attempt for us to reach out to our provider members and develop a program with them where they would deliver face-to-face health coaching to employees. The premise behind this was the thought that the employers wanted to provide services, but they didn't want to be seen as the provider because of privacy concerns, and they wanted the expertise of a clinical delivery system. So we worked in training coaches to follow guidelines, nationally based guidelines, and intercede to work with the employees that signed up and were given incentives to participate. We have since, developed another iteration. We're always improving what we do. So our current iteration of this program is really a whole array of health risk management tools that we can deliver through our membership as value or through our solutions company in other markets. And these are based around, one, the identification of using knowledge you need. That's a tool we have that's a biometric and health risk assessment. It leads to analysis and summary, and then program design around face-to-face coaching. In our Chronic Care Network program, you can see the types of things that the coaches were doing in working with the employees. We did base our program around motivational interviewing, doing goal setting to impact lifestyle and behavior change. Medication adherence was a key focus, as well as sharing any education information that might be needed. So the coaches would collect information and feed it back into our database where we could integrate it with other claims information. I want to move on, though, and talk about how we looked at health and productivity on the productivity side. We chose to use the WPAI tool, version 2, and that is a tool that, as John mentioned, it's in the formal report. We chose it because it was a validated tool that was really quick and easy and had really no cost burden for the delivery because it's a free tool. It's a very basic 6-question set that the employee can answer. And I've given you an example of a couple of the questions here where you can see that they're self-reporting the impact of how many hours they've missed from work because of their health problems, and towards the presenteeism side that Tom mentioned, how much they think they missed in productivity while they were working. So in using calculations from those, you can make some good projections of how that's impacting budget and productivity. The next couple, 3 slides we're going to look at actually come from a study that we're just concluding that was on chronic kidney disease. And in this study, we had, I think, around 340 employees that participated in the program, they took the WPAI and the SF-12 as part of their coaching. And we had about a 37% overall response rate. We have the information from the baseline assessment, but we've just finished our claims run out to do the post-assessment, so I don't have the final study results for you. But on the next slide, you can see the basic demographics of the folks that participated in this study. They were divided by their risk of chronic kidney disease. You can see the types of comorbidities they had, age groups, etc. In the next slide, though, we start to see some impact of the productivity because from the questionnaire, and I think this question actually is off of the SF-12, but they were looking at how they felt the disease interfered with their work and regular daily activities. And you can see the breakout here. I think it's pretty significant that the moderate, quite a bit, and extreme impact is about 30% of the folks participating here. In the next slide, you see the impact of depression in chronic kidney disease patients. And we have a pretty significant 20-25% total of people that reported, self-reported, that they could accomplish less than they wanted and weren't performing their work as usual because of their feelings about that. The lost productivity slide, the next slide, is the initial work off of the baseline from the WPAI. And here you see that the CKD patients reported missing an average of 2.4 hours per week. So they're reporting 7% of their work week as not being productive. And by taking an average wage and doing some calculations, you can see the dollar impact here at the annual productivity loss at the bottom of the slide. The next two slides that I want to go through with you are a different employer evaluation, but I think they're a really good example for you of how you can take some basic productivity information and get meaningful information that your HR managers can use to support their programs. This is an employer who had about a 3-year history of a pretty aggressive program. They ended up in the last 2 years putting an on-site clinic in place and were aggressively addressing chronic disease. They had good attendance data. And I think a barrier that stumps a lot of us as we try to think about how we'll tackle productivity is all the variance there is amongst employers and how they report attendance data. PTO, it's very difficult if we aren't able to call out the absence portion of that. So this was a good case where the employer had attendance data that did address specifically what was absence related and what wasn't. So this slide is looking at those that had a chronic disease compared to those that had no chronic illness. And we looked at the average sick leave. And we were able to demonstrate that those with a chronic condition cost more and had about $246,000 related to the nearly 1,500 additional days that they were missing work. So the employer then wanted to look in the next slide at how chronically ill people that were in their program compared to chronically ill employees that did not participate in the program. And this clearly showed that those employees in their program that were getting management and coaching had less sick time than those with the same types of conditions not participating in the program. This piece of information was invaluable for our employer as they justified their program and understood the impact of the program that they had built. I'm going to wrap up here really jumping on to some lessons learned because, it really isn't that hard to get employers interested in working on health and productivity when you can break it down and start. There's a beginning point for everybody. So I think, having a well-thought-out plan, I just can't stress enough. The more you measure, the better it gets because you learn a lot more about your programs, about your impact of benefits, and then you can better focus your efforts and fine-tune the work that you're doing. Having measurement makes your data actionable. And in my experience with the employers, that's really what they're looking for, is what action can they take to address their situation. I think I'd be remiss if I didn't say be prepared to stay the course. This is still difficult for employees, having what they feel is their confidentiality violated, having an employer that can tell them what they need to do. But we have experience with about every employer that we have worked with. If you have a really rocky first year, it significantly gets better in the second year. And so I think there's maybe just a little time and experience where people are seeing that the program is sound and their private information is protected. It really eases that burden as time goes on. John mentioned really a number of the things here in this last bullet. Health and productivity have to be as important to the employer as all of their other metrics they're interested in. And one of the things that we have seen that has been beneficial in getting the culture of the organization to be supportive is it really isn't enough just to have the top leadership engaged. Because when you get down to that mid-management level where you've got people that determine whether or not their employees can be released to go for coaching, they're the people the employees are coming to and saying, well, what do you really think about this? Because that's their relationship that they usually have a comfort level with. So we like to be sure that we're working the organization from the top down. And we've had a number of employers that actually have tied health goals in their performance objectives, and that seems to have a positive impact. So I really don't think there is a cookie-cutter approach for health and productivity and data management. I think we have to look at each employer and see what their resources are, what their interests are, and then work with them individually. And my final thought in this presentation would be, just as you've heard John reference, and I'll steal from Nike and say, just do it. Get started. Work with your folks. There are a lot of resources out there that aren't expensive, that are doable, and I think you'll be surprised how you can build a program. So thank you.
Okay, so we will end up with our presenters from Pinnacol and Segue. So let's go ahead. Thank you, Vanessa, for participating today, and I assume you'll be starting off. Vanessa Newport.
Thanks, Tom. So Pinnacol Assurance was profiled as case number 9 in the study, if anyone wants to look that up later. Tom, if you want to go to the next slide. Pinnacol Assurance is Colorado's leading workers' compensation carrier. We employ about 600 employees in the Denver area and serve approximately 55,000 policyholders who represent 1 million workers. Next slide, please. So Pinnacol really had 2 initiatives that were profiled in the study. One is the internal initiative, and that was branded a couple of years ago, and it's called Everyday Wellness, and you can see a logo of it there. And the purpose of this program was to bring wellness initiatives to Pinnacol's own employees. This is the particular initiative that I'm going to be talking about here for the next couple of minutes. And then Claire will talk about the external initiative in a few minutes. And that's just simply called Health Risk Management. And it's for a pilot group of our own policyholders. And we have right about 30,000 employees across 300 to 400 companies who are now enrolled in that pilot group. Next slide, please. So just to give you a little background on the internal initiative, really the goal is just to have healthier employees and increase productivity. We use the measurement tool called HPQ Select, and a description of the various measurement tools are included in the study for your reference later. The first year that we rolled out our health risk assessment, which included productivity questions, was in 2009, and we had a 54% response rate. And in 2010, that jumped to a 70% response rate. It could be, for a number of factors, a huge variance, but 2009, we kind of did a soft launch. It's the same year that we went self-insured on our health insurance, and employees were just a little bit sensitive to, what are you getting at? Why do you want all this information from us about our health status? So there was a little bit of a soft launch that we did kind of on purpose in 2009 because of that, and that was a $50 gift card. Of course, was taxable to employees. In 2010, we increased the incentive to a $20 per month health premium reduction for the following plan year for those who are enrolled, and then kept the $50 gift card for employees who were not enrolled in the health plan. Next slide, please. The program components that we had are a comprehensive annual health risk assessment, including the core questions from the HPQ Select self-report survey. We also had on-site biometric screenings that included a full lipid panel, fasting glucose testing, height, weight, and body fat readings. Also offered unlimited telephonic health coaching, access to online tools and interventions, targeted action plans based on the HRA results, and then annual reporting on productivity and program trends. And then we have just tons of internal support programs as part of the Everyday Wellness program. Next slide, please. So what we found at the end of comparing 2009 and 2010 were basically the magnitude of health-related lost productivity costs is too large to ignore. We found that we had about $1.4 million in lost productivity due to poor health, and 75% of that was due to presenteeism. And that was equal to 1.5% of total corporate earnings and 477 lost work days per 100 FTEs. Next slide, please. We also found that the amount of lost productivity by condition helps us focus on where to spend our limited resources with the greatest potential for return. So, of course, 67% we found were overweight or obese, which is very in line with national statistics. 23% was related to back and neck pain, and 14% for anxiety and sleeping problems. So those are what we are targeting. Finding 3 was that improvements in health-related lost productivity can represent a significant business opportunity. So a 10% improvement in health-related productivity has the same earnings impact as an additional $600,000 in revenue. We also found that health-related productivity declined for those who completed the HRA in 2 successive years. So when we looked at the same group who participated in year 1 and 2, we found that there was about $1 million in productivity improvement for that core group of individuals, and that translated to 3.8 days to 5 days of lost time per FTE. That kind of summarizes the main findings that we found comparing year 1 and 2. I'm going to pass the presentation on to Claire Brockbank. Claire's one of our consultants who's been on our project team for the external health risk management program that I talked a bit about a few minutes ago. Next slide, please.
Actually, you can stay there, Tom.
Okay.
Can you all hear me?
I think so, Claire.
Okay, great. So the external program launched shortly after the internal program. The internal program, essentially, we wanted to make sure that Pinnacol was walking the talk, but the external program uses the same tools. We offer it to any of our policyholders at Pinnacol, and as Vanessa said, there are about 55,000 of them. And it's all voluntary, so the incentives that are offered really vary hugely from small policyholders who offer a couple of extra hours of time off to more premium-based incentives like Pinnacol offers. But we're seeing that our average across all our participating companies response rate is about 56%, which is amazing because next slide, these are mostly small companies. As Vanessa said, we have about 300 to 400 companies, and the average size are all less than 100 employees. This is a study that is looking at 3 to 5 years. We'll enroll a number of people. We offer the same kind of benefits that Vanessa is offering on the internal side, except that we provide a fair amount of assistance to these policyholders in how to set up worksite programs and incentives. The reason that we wanted to do this was we started looking at what was driving costs in workers' comp, and a big piece of it was unhealthy workers in the first place. So they were unhealthy when they had their injury, and that lack of health was affecting the ultimate cost of their injury. In workers' comp, people inherently care about productivity because about half the cost of workers' comp is essentially lost wages. So it's while people are while they're recovering and they can't get back to work. So it's a very different mindset than a health insurer who doesn't typically have much on the line for getting people back to work. So productivity was just inherently built into this program. And our goal in it is to discover and document that if you reduce health risk the health risks of the population, that you'll see a positive impact on workers' comp, on productivity, and on health risks overall. So next slide. So what do our people get? So much of this is when you don't have claims data, and a lot of these are small employers, so many of them don't actually even offer health insurance to their employee, and with an average size of less than 100, most of them are getting no data whatsoever for even those who do offer health insurance. So they get a fair number of reports, and it varies a little bit whether they're over 50 or under 50, but for many of our policyholders, they say they have never received any data. And it doesn't take much convincing that the data, that they get the fact that, particularly with productivity, they get it. If you only have 20 employees and somebody's not pulling their weight, they get that it impacts their bottom line, and they get that it impacts everybody else around them. So a lot of them, they're saying, wow, this is awesome to actually have data, but it's not a hard sell, if you will. A big part of this is studying the results of what happens. So we have a control group of policyholders that are not participating. We've partnered with IBI and with Ron Getzel and the University of Colorado and Colorado State University to actually measure the impact of this, both on an ongoing basis and at a pre-post level at the end. So I'm going to take a few minutes to just give some initial results that we have. If you could go to the next slide. So we surveyed all of our policyholders and got about a 40% response rate back in the fall, and about 50% indicate that their companies already received some significant value from this external health risk management program, which again goes back to that you don't always need very intense quantitative data. People see value when they start to see a difference in their employees. And 87% believe that HRM, which is the Health Risk Management Program, will impact the health of their employees, and they make the link to productivity. So that was much higher than we anticipated in that first year, given how little quantitative data we have to report back. Some preliminary data we've looked at with the first 6 months or so worth of data. This gets back to the validity of self-reported data. We have people reporting their health status, and then we also have them looking actually their health risk score based on more detailed data, and they track very, very tightly together. So that's been great. It's really validated that self-reported data is an effective mechanism to use. We have, for the first time, when we set this program in place, there was no data in the industry that actually showed a tangible link between health risks and behavior risks with actual claims. And so we're seeing these are simple correlations right now, but we are absolutely seeing that those who reported higher alcohol compensation, when we trend it back to their last 5 years of workers' compensation claims, they're absolutely associated with higher claims. Same thing we're seeing with smoking status. It's tied to greater lost days, and we know that it takes longer to get into surgery. Your recovery rates are longer. We see participants who wear seatbelts are less likely to have a claim. And then we see sleep is related. And again, all of these are intuitive, but we haven't seen this kind of data before. So it's changing the conversation we have with our policyholders to say, this isn't abstract that a healthier worker is going to have better results. Here's our data. Get your folks to get a little more sleep, wear their seatbelts. They're not always the really big issues. So this data is again, self-reported data. It's data that policyholders haven't had before, and we believe it will drive change as we continue to study the impact of this program over the next 3 to 5 years. So with that, I'm going to wrap it up and turn it back to Tom and John.
Thank you very much, Claire, Vanessa, Gaye, and John. We have a few minutes left for questions, so I understand that questions are oftentimes difficult to ask on such a big webinar, but we do have some experts here at your disposal. By all means, you can email John or me and get a copy of the search report. Really just touched on a number of different things. I particularly appreciate the opportunity to hear from Claire about working with employers in the workers' comp arena around health risks. I think that's a fascinating and important set of findings to the broader issues of population health. So